Thank you for joining us today. My name is Richard Laurie. I'll be your host for this webcast. Our speaker today is Dr. Stephen C. Malamud. Dr. Malamud is an attending in medicine in the Division of Hematology Oncology at the Beth Israel Medical Center. He is also Associate Professor of Medicine at the Icahn School of Medicine at Mount Sinai and Director of the Breast Cancer Research Medical Oncology at the Continuum Cancer Centers of New York. Dr. Malamud received his medical degree from Albert Einstein College of Medicine, Bronx, New York, and completed residency training in internal medicine at Beth Israel Medical Center. He then earned a fellowship in medical oncology from Mount Sinai. He is board certified in internal medicine and medical oncology. Dr. Malamud's primary professional interest and research focus is breast cancer and drug development. He has developed or helped to develop new and improved therapies for patients with breast cancer. Dr. Malamud, thank you very much for joining us today.
Well, again, thank you to all the participants tonight who are taking time out, either from their offices, if they're not in New York, and hopefully wrapping up their day. I see a couple of names out there that seem familiar. Welcome aboard. We're going to spend the next hour talking about what I believe is an exciting new technology and helping us understand and to better treat patients as they enter into the latter phase of their adjuvant therapy with hormone-positive breast cancer. So let's just get started. The first is audience participation. We're going to ask you to try and rank for us what you feel to be the highest ranking in terms of unmet medical needs in deciding what's to do going forward with patients beyond their 5th year of adjuvant therapy after their initial treatment. Is it the efficacy of effective extended endocrine therapy is modest in unselected population? And I'm going to show you the data that supports this, where the data indicates only an absolute improvement of about 3 to 6% benefiting over the 5 to 10 year period. Is it that endocrine therapy, and certainly extended endocrine therapy, is associated with serious toxicities, and that could be long-term toxicities, potentially fatal, like endometrial cancer, bone loss and fractures, and individualization of therapy for those at the highest risk is therefore enviable and a priority. That the side effects ongoing, the quality of life of patients as they're receiving endocrine therapy is a serious issue. Compromising compliance was another issue, but the side effects, again, are something that you hear in the office every day as patients come in noting the side effects of their medications. Is it the fact that there are no really other genomic tests out there? Oncotype DX was never designed for long-term late recurrence assessment, and the current genomic tests don't provide information regarding late recurrence, and the likelihood of benefit from extended adjuvant therapy is not assessed by those technologies. Is compliance your main concern in terms of getting patients to be more compliant with their medications, not only in the first 5, but in the second 5 years of potentially extended therapy? And is the current inability to establish a 10-year treatment plan a problem? Is that a hurdle that patients want to hear what they need to do over the 10 years rather than 5 years? If you could just put those to your votes in a rank order, we'll move on. All right, it looks like we're concentrating for the most part on efficacy issues, long-term toxicity problems, and compliance as our top 3. Let you see what your colleagues have voted for here. Well, let's bring us back to some of the data and to try to understand what it is that we're actually doing in treating patients with early stage breast cancer. This is the graph from the ATAC trial that looked at a comparison of anastrozole versus tamoxifen versus the combination in the adjuvant setting. This was not an extended adjuvant program, but if you look at the recurrence risk, this is the first 5 years, about 9% versus 7%. But the point to be made here is it's really the 50% of the recurrences are actually taking place in the 5 years after the first 5 years of hormone therapy are completed. Most of the patients, nearly 90% of them, are remaining disease-free, but another 10%, or half of the total recurrences, are taking place in the 5 years after the cessation of standard hormone therapy. And the question was raised as whether or not 5 more years of endocrine therapy for all patients would be worthwhile. Well, there were several trials put together. Some of us who have been doing this for a while remember trials even more ancient than these, back in the 80s, looking at extended therapies for tamoxifen. But here are those that are the most recent data. That from the MA17, which is the first looking at the switch from 5 years of tamoxifen over to another 5 years of letrozole, an aromatase inhibitor. Most of these trials were in postmenopausal women, since they included an aromatase inhibitor. The Atlas and ATOM trials had premenopausal women, since they were tamoxifen-based programs. If you look at the MA17, a goodly number of patients. Paul Goss reported on this twice, and a 2.5-year follow-up period. Many of the patients crossed over because of the advantage of letrozole in that setting. But if you look at the risk of recurrence between years of 5 and 10, the absolute improvement is really only about 5% here, actually a little less than 5%. If you look at the APCSG trial, also postmenopausal women, that looked at anastrozole versus nothing in about 900 patients, a 5-year follow-up. Again, there was an advantage to the addition of anastrozole, but quite modest, really measuring not more than 4%. The Atlas and the ATOM trials looked at 10 versus 5 years of tamoxifen in the pre- and postmenopausal women, with large numbers of women, almost 7,000 women in each trial, with 10 or 9 years of follow-up. And again, an advantage, but modest, for the addition of another 5 years of tamoxifen on top of the original 5 years, 4 versus another 3 or 4%. Again, small the benefits, but because of the size of the trial, statistically important. Does that mean that everybody in these trials should be getting another 5 years of extended hormone therapy? Well, the risks are problematic, and the risk in assessing becomes an issue in terms of risk and benefit. If one looked at the Atlas trial and sort of picked it apart a little bit, for every 600 women who were treated with tamoxifen for 10 versus 5 years, you received an improvement that 16 recurrences were prevented. Here they are. But for those 16 recurrences that were prevented, that was paid for with 5 endometrial cancers and 2 pulmonary emboli. In the MA17, the extended letrozole therapy, for every 12 recurrences that were prevented, that was paid for with 13 new cases of osteoporosis, 4 bone fractures, and 1 thromboembolic event. The long-term and short-term quality of life impairment while on the drug and afterwards remain as thus far unassessed. So the second question would fall again back to my audience. What are your concerns regarding extended endocrine therapy? Again, we can put this, it's not rank order here, but it's safety issues in terms of endometrial cancer, ischemic events, pulmonary emboli, or bone fractures, quality of life issues, and that's while on the drug, hot flashes, weight gain, dyspareunia, and other sexual side effects, loss of libido, adherence and compliance, the costs of it, and again, if you can't figure one to be more than the other, all of the above, or none of them really bother you very much. Yeah, I think that's pretty much the consensus for most of our colleagues, that all of these play a role. Some are more important than others, such as for some of us the safety issues and quality of life, but all of them are important in our assessment. Okay. Well, compliance was one of those potential answers, and compliance is a problem with women on anti-estrogen therapy. Dawn Hirschman has published just recently on the compliance rate in New York based on records, and again confirmed this data that came from the California groups of a loss of about 10% compliance for each year on drug. So by the time you reach your 5th year, only about half of our patients are actually taking the medication that we expect them to. Price and cost of drug becomes a significant issue as well. The other reasons for discontinuation, for the most part, end up being side effects, worried about the risk of taking the drugs in the first place. They don't like taking medications. but costs and side effects remain the prominent issues for why people drop off drug, such by the end of the first 5 years, as I've said, almost the majority of patients are not taking what we expect them to be taking, or hope for them to be taking. So what do you think is going on in your own office? I think I'm equally negligent in asking my patients and confronting them the way they should be. Are your patients taking the medications as you prescribed? They miss doses and tell you about it, or your nurse or nurse practitioner. They miss doses and don't tell you about it. Or they've stopped taking their medications altogether and they tell you that they've done that, or they're more secretive about it and they've stopped taking the medications and are still taking a prescription from you every so often and harboring it. Okay, looks to be about a third of you think that your patients are keeping you in the dark. Now, still about 40% are convinced that their patients are perhaps not as honest as they should be and are not taking the medications 100% as directed. That's about the national average. What do you think your patient practice in terms of the percent of patients who are compliant with their endocrine therapy? And we'll take some degree of compliance here. Let's say 80% of the time they're taking their drugs. That would be really good if a patient was taking their medication 80% of the time. Let's see how many of you think that that's the case in your practice. Okay, about 3/4 of you think that your patients are actually taking it at what might be considered appropriate dosing, about, in this category 2 here, between 75 and 90%. We'd like to improve upon that, especially if we're going to be asking patients to move into a 10 years worth of therapy. And the traditional tools that we've used to decide upon hormone therapy in patients with breast cancer are not adequate at the 5-year mark. What have we used up until now? Well, the same things that we used at the time of diagnosis. Clinical pathological factors are really inadequate for that. We've used TNM, or just staging. The higher the nodal burden, the more likely it is that we're going to be offer and sincerely impress upon our patients the importance of extended therapy. We've used patient characteristics, their age, their menopausal status, other comorbidities, either to give additional medication or not to. The initial endocrine therapy. If they receive tamoxifen up front, it's not a hard maneuver to advise them to go on to a switch therapy with an AI afterwards, or vice versa, or some sort of sequence. Tolerability, well, the question would come, how well did the patients tolerate their first 5 years? Was that significant encumbrance for them in terms of quality of life or not? Are they more likely to go on to another 5 years without a squabble? Patient preference, do they want to or do they not? And of course the cost issues. But these are not the best way of individualizing care in 2015. The first generation molecular tests that we've had really were never designed to look at late recurrences. They were designed to evaluate for patients for risk at the time of diagnosis, establish a prognosis, for which Oncotype, Prosigna, and MammaPrint have been key players. But only one, Oncotype, was used for the predictive value in determining the advantages of chemotherapy in the first 5 years. But at the last 5 years, the second 5 years, these were never explored or designed for that use. So ASCO in 2014 put forward its practice guidelines that identified the need for a biomarker to selectively predict early versus late recurrence and determine whether or not longer durations of adjuvant therapy are clinically indicated, and in which population, of course. Well, in the choice of any drug or treatment, we have a sort of a 4-quadrant approach that we can look at. The drug may be beneficial and tolerable, which would be nice. The drug works and it has side effects, but they're okay. We can deal with them. The drug could be not beneficial and not tolerable, and this would be the exact opposite. We don't want to give something that doesn't work and is intolerable. This is poison. This is not worth giving patients clinically. Similarly, you may have a drug that's beneficial and tolerable. Not beneficial but tolerable. Well, this is something that doesn't work, but you can give it, so this is a placebo, so you like to keep away from both of these two columns. This is something that doesn't hurt but doesn't harm either. And this one that hurts and doesn't do any good. And this is that category we find most of our agents that are beneficial, and there's some side effects, but we can again deal with them. We like to sort of like keep out of this category as well. This is where we'd like to be, picking drugs and treatments that are beneficial and work. Well, and that's where we come to the breast cancer index. This is a gene expression-based second-generation biomarker for patients with hormone-positive early-stage breast cancer. It actually is two biomarker tests in one. The BCI has a BCI prognostic score and a BCI predictive index. The prognostic score, the BCI prognostic index encourages the risk of, assesses the individual risk of recurrence at 5 to 10 years, while the BCI predictive index predicting the likelihood of benefit from the addition of additional hormone therapy. Prognostic for risk assessment, predictive for the benefit of additional hormone therapy. This one individualizes that risk. When you see it appear on your report, it shows that as a numerical result on a continuous curve. It is an algorithmic combination of several proliferation pathway genes, and the H/I index, which we'll talk about later on. The genes, the BUB1, SENPA, and NK2, NEC2, the RAC, RM2, and the HOX-IL11 ratio are unique genes assessed in the BCI and have no overlap with those that you might be familiar with the 21 gene assay that you're familiar with. The BCI predictive is looking for the benefit of the additional hormone therapy. It is reported out as a high or low likelihood of benefit. It is the assessment of a ratio between the two genes, HOXB13 and the IL-17BR. How does the BCI work? Well, there are two parts, and I'm going to try to explain them to you now. The BCI has the genomic information from two key domains, the cellular proliferation. That is key in determining the risk for recurrence. At the prognostic portion, looking at the proliferation genes that I've illuminated for you a few minutes ago, and estrogen signaling. The proliferation gene signature is the marker for early recurrence. Those are the genes that are involved in that process. The second portion, also important in the late recurrence, both for early and late distant recurrence, is estrogen signaling. These are two unique genes that are involved in the estrogen signaling pathway. When that ratio is high, it indicates that the signaling pathway is intact and can be manipulated and controlled by anti-estrogen therapy. So when the H/I index is reported in the BCI predictive, it will tell you or indicate for you on that report the likelihood of benefit from extended therapy, and this is nicely reported out as a high likelihood versus low likelihood of benefit, and I'll show you that in a little bit. This is the report, which I'm told will be likely to change some in the near future, the way it's presented. And again, it's served out to you in two portions, the prognostic portion and the predictive portion. There's ample evidence for the development of BCI index, first as biomarker development for the first decade in a variety of translational research papers. And lastly, the three pivotal trials, which I will go over with you now in some detail, that look to its clinical utility in a late treatment of adjuvant breast cancer. And lastly, the health economics in terms of weighing the cost-benefit analysis of doing the test versus continuing therapy without assessment. Now let's look first at the BCI prognostic portion, which is the risk of recurrence. These are the three trials that we use to support that. The Stockholm randomized trial reported in 2013 in CCR. Approximately 317 patients in the cohort. They were all postmenopausal. they were hormone positive and lymph node negative, and they received TAM or not. The multi-institutional trial, also reported in CCR in 2013, was a multi-institutional cohort of consecutive cases, about 350 patients, with both pre- and postmenopausal women, hormone positive, of course, and lymph node negative, and they also received tamoxifen. And lastly, the TransATAC trial, another randomized trial reported out in Lancet Oncology, and validation of the RCT and head-to-head against Oncotype was the goal. About 665 patients, postmenopausal, hormone positive, and lymph node negative. And they received, if you remember, either tamoxifen or an anastrozole. And in the 3 study cohorts, over 340 patients looked at in these trials. We look at this is the data from the TransATAC validation trial. If you look at these are the curves for recurrences in the patients all patients on that trial. You can see that there are 2 curves that are rising, an increasing recurrence rate, and these are the 2 curves for both the intermediate and high risk categories. And this is the low risk category down here. The high and low risk, the high and intermediate risk categories sort of track together very closely, so they were combined, and they're here in this grouping here, indicating that those patients, and about 60% of the patients showing up in the BCI low risk category, with less than a 4% likelihood of recurrence in years 5 to 10, were compared to, and quite differently in terms of p-value, between the group that were either high or intermediate risk, where there were about 40% of the patients, and a variation in terms of risk of recurrence of about 3.5 versus 13.5%. That's a 10% gap in recurrence rate between those classified high versus low risk. If one looked at Oncotype in that same patient population, although valuable in assessing the risk in the first 5 years, it was not adequate in determining what the risk of recurrence might be in the years 5 to 10, with p-value at 0.21, and here with 3 zeros after the decimal point at 0.001, with a clear ability of able to call out those patients who are likely to have a late recurrence. Both biomarkers actually predictive for early recurrence. So if one looked at the stratification also by Oncotype versus BCI at the 5-year mark on that same trial, these are the patients who received the 5 years of an aromatase inhibitor only, not the tamoxifen group. You can see how the Oncotype, either RS low, intermediate, or high, they're all sort of bunched up together between 6 and 7.5%, while the BCI for those 5 years that followed, again, we have more than a 12% variation in risk of recurrence between those 60% of the patients coming in at the BCI low versus those 40% that were coming in with a much higher risk of recurrence in the high or intermediate categories. And this was the same whether or not one looked at the Stockholm trial, the multi-institutional trial, or the TransATAC trial, which I just went over with you. Pretty much the same information. Interesting that the risk of recurrence was higher in this middle category, the multi-institutional. Many of them, or 30% of them, had gotten chemotherapy, which may imply that that was a riskier population anyway. But they were still able to pull out those patients who were at low risk, even in that population. What about the second part, the BCI predictive? This is where I feel that the importance of this technology becomes exquisitely important as we each enter that 5th year in terms of predicting benefit for more treatment. So the BCI predictive has shown consistent evidence as an endocrine responsive biomarker. This is that H/I index between those 2 genes, the HOX and the IL-17, I'm sorry. In the Stockholm trial, it was the initial evidence. This was a randomized trial where BCI predictive was able to predict benefit from tamoxifen. This was a randomized trial done many years ago comparing tamoxifen to placebo. And this is, again, similar curve to what you might remember from the NSABP14 on the 21 gene assay. Here, the HI low, indicating that the endocrine response signaling pathway is not particularly valuable, and the curves are very close. Whether or not they were treated with tamoxifen or not, benefit from tamoxifen is limited. While here, the high signaling pathway, indicating a responsive endocrine pathway, is showing that the tamoxifen-treated group did a lot better than those that were untreated, indicating tamoxifen responsiveness. If one looks at the trans-ATAC data, again, there was complementary evidence here that the BCI predictive was able to show the advantage to the adding the estrogen therapy. And lastly is the MA17, the extended adjuvant program done at the NCI Canada, reported out by Paul Goss, looking at whether or not the addition of an aromatase inhibitor after tamoxifen was valuable. Here, again, the question being, was BCI predictive helpful in predicting extended therapy? And again, we looked at, again, about 30-odd% of our recurrences in the parent trial, looking at the power to look at these, the study. This was a cohort of about 250 patients out of this trial. This was reported in the JNCI. Most of these patients were lymph node positive, about 60-odd%. All of them were hormone positive. Most were postmenopausal, and they were treated with 5 years of TAM. And I could show you how that looks. This is the study, tamoxifen for 5 years, followed by randomization to placebo versus letrozole. The code was broken after 2 years, so many of the patients who were getting placebo hearing their data switched over to the letrozole arm. But this is how the parent trial panned out, where you see that there was approximately a 4% difference in recurrence rate, disease-free status, by the time the patients reached the end of the trial. Again, a modest improvement, but enough for many of us to suggest extended aromatase therapy for these patients. There was really very little way of figuring out who was actually benefiting, but if one looks at the selected population, the BCI predictive was associated with a nearly 2/3 reduction in risk for recurrence. Here's the BCI predictive, the high BCI, meaning that the endocrine pathway was intact and likely to be benefited by additional therapy. And here the reduction in risk was about 66%, but an absolute benefit of 16.5%. And that's, again, not a small difference with a p-value of 0.007. If one looked at the BCI low predictive, meaning that the estrogen pathway was not particularly intact nor helpful in additional therapy, there was no real benefit to be derived, with a very few percentages here, maybe a 2% difference with a negative or insufficient p-value. So a low BCI had no particular benefit, and again, a significant interaction between the high PCI and therapy. And across all studies, about 50 to 60% of the patients showed a low likelihood of benefit, meaning that 40% of the patients would be in this high predictive or valuable to move on. Someone's asking a question. Do we want to take that question now? Do you want to type out a question for me? Okay, until I see one, I will continue. If one looks at the other parameters that we often use to assess risk and benefit, if one looks at the other tumor parameters or patient parameters, age, tumor size, grade, hormone status, whether or not ER, PR, HER2, nodal status, yes or no, treatment, and none of these, if you look over here, either adjusted observed response or unadjusted, you can see that the p-values are not particularly indicative of any kind of value in this analysis. The only factor that was predictive of response was the H/I index, whether or not it reported out as high or low, with again significant p-values, the one I just reported out. And if one looks at the adjusted overall response, again still 0.006. So, in 2015, as patients enter their 5th year of therapy, what is it that you're using now to help you decide if the patient should go on to additional 5 years of therapy between years 5 and 10? And again, if you could rank these in some order, we'd appreciate it, and perhaps we could even discuss them in the Q&A a little bit later. So this would be prior to any new technology, such as the one we're talking about today. What have you used since the publication of ATOM and Atlas and the MA17? What have you been using to help decide what to do at year 5? As we pointed out in the beginning, most of us, for the most part, have been looking at stage, clinical features of the patient, clinical features, pathological features of the tumor. Someone has mentioned molecular features. I suppose that means one of the other genomic testing. I'll let you see what's going on in the voting out there. Pretty much what I've just told you, but usually those top 3. And I guess we all believe that tolerability is something that our patients can cope with, and comorbidities also shows up occasionally. Okay. Well, when you enter into that 4th or nearly 5th year, a lot of questions come up from the patients. Breast cancer patients, in my practice, having once been a more general oncologist, tend to be the most well-informed out there. So they will come in and do already, how long do I need to take this pill? Oftentimes asking the question the first time you see them after prescribing it the first time in year 1. Should I continue treatment for another 5 years, having read something either in the lay press or in a brochure that they've acquired from one of the breast cancer support groups? They've read about there's new data recommending 10 years, that the paradigm is shifting. What does that mean for the patient, and do I fall into that category? And occasionally someone will be so bold as to ask if there's new technology that can actually help in figuring out if I'm going to do any better with 5 or 10 years of therapy. So patients may benefit from BCI at several points in their diagnosis. Today we're focusing at years 5 and beyond, but in patients at the time of diagnosis, it has been used in that setting for patients faced with challenges in terms of toxicity or poorly compliant. It may provide some clarity for those patients in helping them decide on therapy. If one could show them if these non-compliant or very frightened women at day 1 can be shown that they have likely that they will finish at the year 5, that might be encouraging them to be more compliant in terms of their treatments over the first 5 years. For patients at year 4.5 to 5, this is where I have used it predominantly for patients who are approaching their 5th year or their 5th anniversary. They're looking forward to stopping, but here BCI may help in further understanding whether or not they are in that group who will benefit from treatment. There are some patients clearly in that category who I would not to do a BCI because I've convinced that I would continue, and this would be in those groups with heavy nodal burden. BCI has not been tested in the nodes group over in 2 categories or more than 3 positive nodes. For patients who are approaching or beyond the 5th year, already in adjuvant therapy into their 5th, 6th, or 7th year of therapy, and they're either suffering or complaining on treatment or just quizzical as to whether or not they're actually benefiting from additional therapy or have other reasons that they may want to stop, but potentially for childbearing, maybe they've already suffering some from osteoporosis, the musculoskeletal syndrome is getting to be too much for them. Again, BCI may be helpful in at that point in terms of re-emphasizing the need. If they're a BCI, it comes back a high risk of recurrence and a high likelihood of benefit, they could be encouraged to move forward, or for that matter, if their indexes and testing come back with a low value for further therapy, they may be stopped with some confidence and reassurance that that's the right thing to do. So let's look at a couple of cases and see if we can reach some agreement here. This is case 1. She's a 65-year-old young female physician, a breast radiologist. She has a T2N0 intermediate grade tumor. Ki67 is low at 5%. She did have oncotype score done, which came back in the high intermediate category. She did elect to receive chemotherapy and then went on to 5 years of tamoxifen. She has a history of rheumatoid arthritis and cardiomyopathy at her 5th year mark of tamoxifen. She really is against the idea of any drug-related adverse event. She's already suffered 20 pounds of weight gain on the first 5 years of tamoxifen. It's tough to figure out whether or not that's the donuts or the tamoxifen, but she's also gaining some weight there, and she's anxious to get off of the drug. But because of the tumor size and the oncotype score, she and you decide to continue the tamoxifen. And at this point, she's interested and comes in and says, what about doing a BCI to see if I need to be on any more tamoxifen? I think many of us would question why isn't she on a aromatase inhibitor, and it may be coming from the symptomatology that she already has from her rheumatoid arthritis. So she gets a BCI test done. This is how the report looks today. That may be changing soon. There are 2 parts. The BCI predictive, and she's coming back with a low risk of recurrence. On the curve, she's here in that low risk category, predicting for a risk of about less than 4%. And at that same time, here is the BCI predictive, and here we see a low likelihood of benefit for additional endocrine therapy. She does not, this is the curves from the MA17 trial. She is not in this category. This is just giving you this as a point of information. It's not that she is necessarily on these curves anywhere, but she would be in this category here without showing any particular benefit from the addition of another 5 years of therapy. She is not in this category. So with that information, she decides that she's finished with tamoxifen. Case 2 is a 52-year-old woman. She had a T1C tumor, also intermediate grade, grade 2. She's N1 with a 0.25 millimeter micrometastasis. She gets a wide local excision with radiation therapy. She also was treated with chemotherapy, after which she receives tamoxifen for 5 years and went on for another 2.5 years on exemestane therapy, and they are now complaining of consistent side effects. Every time you see her, she has decreased libido, achiness, muscle pains, vaginal dryness, and we can list a whole other list of potential possibilities here. Hopefully her bones are intact and her bone densities have remained stable. And she's coming as well with information that there is a test out there that may help her. So she gets a BCI test done. And she comes back with a result that indicates that she, in fact, has a high risk of recurrence. She's out here in the 8% range over the next decade, actually in the 5 years post-completion of her tamoxifen. She's already at the 7.5 year mark. She wants to get off of it. This is telling us that she may benefit from continuing. And even more importantly, when we look at her likelihood of benefit from the addition of the extended hormone therapy, she does show that she would be in the category of women who would have benefited from the addition of additional exemestane or aromatase inhibition. So with this information, she looks at the data and her decision is to continue therapy. She may be having troubles on the aromatase inhibitor and is debating whether or not she wants to go back to the tamoxifen. And this, of course, will not begin to answer the question, would she do better on tamoxifen or aromatase inhibitor? 2.5 years of the aromatase inhibitor may actually be enough for her, and she could safely go back and complete another 2.5 years on tamoxifen, which hopefully she tolerated better. Case 3 is a much younger woman. She's 37. She had a small tumor, T1B tumor, also grade 2 with hormone positivity, both for ER and PR. Her oncotype DX is low in the low risk category. She was staged as a T1B, stage 1 tumor. She did not get chemotherapy. She got endocrine therapy, obviously tamoxifen, for nearly the first 3 years, 2 years and 9 months. And she also has been complaining of side effects every time she comes to your office, with either decreased libido, irregular menses, pelvic pain. Next month, maybe some weight gain, maybe some hair loss, maybe muscle cramps. And she too is interested in finding out whether or not she needs to be on this medication. And you're wondering about her compliance with this organ recital of problems. So she too gets a BCI test done, and she comes back with data that indicates that she has a low risk of recurrence beyond the 5th year. That's what this is all about, and a low likelihood of benefit beyond the first 5 years of anti-estrogen therapy. So with that information, one could approach her and try again to convince her that if she were to gut it out, as it might be, for the next 2 years, she will be finished, and her treatment will be the more commonly completed at 5 years, and perhaps compliance will be reinforced that way. And in this case, these are all actual cases, and she decides that she will pursue the first 5 years and then stop and then try and start her family, which is, again, an appropriate decision on her part, I think. Case 4 is a 54-year-old, diagnosed in 2007, 2.3 centimeter tumor. She's node negative, very low intermediate score oncotype, no chemo, got 5 years of TAM, stopped it 2 years ago. So she's been off for 2 years, and she's actually considering going back on therapy based on data that she's heard on the ATOM and ATLAS trials. Very well informed. She comes to your office, you do the BCI, now at year 7, and she too comes back with a high risk for recurrence and a likelihood for a high likelihood of benefit from the addition. So with a 2-year hiatus, similar to the patients on the MA17, I suspect, and yes, she decides now postmenopausal with a 2-year hiatus, she will go back onto hormonal therapy and continue an aromatase inhibitor for an additional 5 years. So actionable information from the BCI, you have 4 different categories: a low risk of recurrence and a low likelihood of benefit. This is relatively simple, that we can consider completion of the endocrine therapy in 5 years. If patients are already beyond their 5th year, one can consider discontinuing that. Patients who have a high risk of recurrence and a high likelihood of benefit, this is another 30%. These are patients for whom extended endocrine therapy makes considerable sense, and they should be discussed with that in mind. Also might, again, emphasize the issue of importance of compliance for these patients. The patients who have a high risk and a low likelihood of benefit, I find particularly not only intriguing but problematic. These are those patients who you are saying have a high risk of recurrence, but the endocrine pathway is such that additional endocrine therapy is not going to be terribly helpful for them. This is a group who I think we'd like to see in the future for considering clinical trials or other adjuvant therapies other than straightforward anti-estrogen approaches for these women, and we'll have to see how that generates from the laboratory and from the hypothesis into a clinical trial. And lastly are those patients with a low likelihood of risk but a high likelihood of benefit, and here is predominantly an issue in terms of how are the patients feeling. Are they willing to continue more therapy for a small absolute benefit that they may in fact achieve, but they have a low risk in the first place. And this is, again, for the most part, going to be determined by the patients, their fears, and their side effects over the first 5 years. There is a variety of information out there that you can get from your representative. Ordering the test is relatively straightforward with a single form, and the company, Biotheranostics, will handle all the legwork from their offices. And again, just to reiterate, it is a quantitative assessment of risk for patients for endocrine therapy extended beyond the first 5 years. Treatment decisions, of course, require other decision processes and recurrence evaluation. This test was developed and its performance is determined by biotheranostics, and it's not as a test. It doesn't need nor has it been cleared by the FDA, and it's used in clinical practice.